it occurred to me, John, seeing as this is the first time you and Anders have met, would you like to put some of those questions you had in your final slide to Anders?
Yeah, that'd be great. I mean, to me, what do you think are the most important things about trying to decrease or squash that surgeon heterogeneity?
I mean, in my opinion, this study is a little bit an eye-opener for us where we really describe the differences, and we also identify differences between experienced surgeons. So I think that is also important to, as you mentioned, what is the annual caseload you should have to perform your skills? And even if you're an experienced surgeon, you may be not the best surgeon. You may not be as careful as you should be. So I think that is the training of the new surgeons is to train them step by step before they can perform the whole procedure. To the training program is important, and also how to maintain your skills. So there are two very important things here. And I guess this is quite obvious for everyone, but it cannot be mentioned too many times.
Thanks so much. Now, Sigrid, I wonder if you've selected the most helpful, perhaps most voted for question that we might turn to first.
Yeah, so on that question of training, Anders, we have a question here from Dr. Declan Murphy, who's asking, there was a mixture of public and private centers in LAPPRO, and presumably the trainees get their training at the public centers. I don't know if that's true, you can tell us. So he's asking, is there a confounder in interpreting the surgeon heterogeneity, as the different trainees may have been doing significant steps under the name of a particular surgeon in public centers?
Well, the distribution between public and private centers is not equal. There were only two private centers performing this, and at both centers the surgeon was quite experienced. So, and that was not the case at the public hospitals. So to compare public and private hospitals in a LAPPRO study is quite difficult because they're not equal. So, but of course, training is carried out at the public hospitals and not really at the private centers.
So, sorry, Sigrid.
Yes.
If I may, so we have two questions from the editor-in-chief, Freddie Hamdi. I think as the editor-in-chief, we'll allow him to. And he says, thank you for great presentations. Two questions. What do you think is the impact of surgeon heterogeneity on the conduct of RCTs? How should we mitigate for this variable, Anders? And you analyzed surgeon heterogeneity. What about patient heterogeneity, case selection, and fundamental differences in pathology requiring variable interventions?
Well, thank you, Freddie. Two very important questions. I also would like to congratulate John and the team for performing the famous Brisbane study. That's really fantastic. And that's the best study you can do if you want to compare two different methods like open and robotic surgery. That's the way to mitigate all the possibilities for error. There to have one very experienced surgeon in each of the two arms. So I think that's the way. But also when you perform a randomized clinical trial that you did to adjust for as many factors as possible that you believe may influence the result, the outcome. So, and that's also what we've done in the LAPPRO study in the different papers we published. We try to, every time we have longer follow-up to report, then we try to adjust for the same confounding factors every time. I think that's also important. So, and there are many things that can influence the outcome. So adjustments, very important. And of course to randomized clinical trials, that's the best way you can do it, to compare two different methods.
Thanks, Anders. John, did you have something you wanted to mention on that?
Yeah, I just think that, I mean, a randomized trial is the ultimate thing you need to do. I totally agree with Freddie Hamdy on that. And we thought of having a multi-surgeon, multi-center trial when we did the Brisbane, before we started that, but it just would have biased against robotic surgery. We're in a learning curve. And as I said before, that it's easier to randomize into a study when the technology, whatever it is, when the technology is new and it's not publicly available to the general community, and there's already not a bias to the general community that that's the best treatment, because then it'd be hard to randomize. But then you need to make sure you've got an experienced and a technically competent and also really well-trained technical surgeon, and that's what we had with our robotic surgeon, who did 2-year fellowship in an incredibly high volume unit with Bjartell in the States, and I was the most experienced surgeon at Royal Brisbane, so I did the opener.
Excellent. Thanks, John. A great additional comment. Sigrid, what have you chosen for us next?
Well, I'm listening to this interesting discussion because, we have the world experts here in the RCTs of surgical techniques. I'm curious, in terms of going forward, given this study where we show this massive heterogeneity, even among, experienced surgeons, in terms of study design, and not just in urology, but the PI of LAPPRO, Eva Haglind, who's also on the call, she's a colorectal surgeon. I mean, is it so that we cannot do randomized controlled trials in evaluating surgical techniques because of this heterogeneity? Or is the answer then to do what you did in Australia with a single surgeon design? What do you think?
I don't think it needs to be a single surgeon design. I mean, ultimately, the ultimate trial is a multi-center, multi-surgeon trial, but you just need to make sure that the surgeons you use in those centers are well trained at their technique. They're the best at their technique. For instance, in a laparoscopic versus robotic assisted laparoscopic trial, it'd be great for the surgeons most experienced in their technique to do all the lap and the most experienced in their technique to do all the robot, rather than surgeons who do both participate in the trial. So that might be a criticism there. But so providing you've got the surgeons and they've been trained well and their outcomes are good, that's when you can compare the technologies rather than comparing the surgeons. And the randomization will hopefully take out some of the heterogeneity in both patient factors and surgeon factors.
I mean, I'm thinking of that expression, it's not the tool, but it's who's using the tool. Or as Peter Carroll sometimes says, it's not the song, but it's the singer. So it's interesting when you do studies comparing techniques, when you have this variability among the surgeons. Great.
I'm going to pick a question from Hide Yamamoto, if that's okay, from Maidstone. He's a co-investigator on our Translate trial. Transrectal versus LATP prostate biopsies. Just to plug there. So Hide asks, patients want to be operated on by a surgeon with good outcomes. Why focus on surrogate markers such as surgeon volume or experience, which only explain part of the outcomes? Why not publish independently collected and statistically adjusted and individual surgeon outcomes data so that patients can decide for themselves? Anders, can I put that to you first?
Yeah. Well, I mean, different countries are different. In Sweden, the patients are not really supposed to ask about the surgeons. Sometimes they are happy and they believe that they will always get a very good surgeon. That's the way it is in Sweden in most cases. Of course, we have some private hospitals where you can select the surgeon you would like to be operated on by. But so that's the case. But I mean, I think things will change. Patients will be more and more aware of that there are differences in performance between surgeons. And I think in the future, they will be more interested in getting the best surgeon. So I think it will
Do you agree with
change in the
Hide?
future.
John, what do you think?
Hey, that's difficult. So, look, I'm very proud of the Australian healthcare. We've got great urologists in Australia, all of them. They're wonderful, but there's obviously some heterogeneity differences. The trouble about the information to give patients, it's important to give patients information. They want to pick their surgeon. They obviously, everyone wants to get the best outcome. But if you just look at that PT3 difference, if you're going to publish that data, then surgeons' PT3 and positive margin rate can be operating on a clinical T1C 4+3, and he's got a bit of focal extracapsular extension, and he's going to have a low positive margin rate, whereas if you're a surgeon that operates on bulky, palpable disease 4+5, you're clearly going to have extracapsular extension, which is PT3, but you're going to have a much higher positive surgical margin rate than the other surgeon. So if one surgeon sends that group of patients for radiotherapy, but just operates and publishes his PT3 data on those cases where they're most likely to be negative, he's going to look like a better surgeon, but that doesn't make him a better oncological surgeon at all. So it's how you interpret what's clinically available to the community that's important, and I don't know the answer to that, but the community is certainly going to want more.
So we're going to try and get through 3 questions in our final 3 minutes from Paul Cathcart, Catherine Lovegrove, and Alan McNeil. Although, have you just answered Paul Cathcart's question, Sigrid? I think you might have done. So let me turn to Catherine Lovegrove's question. As trainers, will this publication affect how you train your residents and registrars? And if so, then how? Catherine Lovegrove is a trainee of ours in Oxford, and it's a good question. Anders, if I could go to you first again.
Well, we have this double console equipment now, so we can one experienced and one surgeon, one beginner, sit on the opposite side of the console and teach step by step how to perform the procedure. So as I mentioned before, in training you start first with the less advanced part of the procedure, and then when you have shown that you have do that very well, and then you go to the next step of the procedure, and then it may take a long time until you can perform the whole procedure, but I think that's a safe way to train our younger surgeons.
Great. John, I'm so sorry to cut you off there. I might just let Sigrid put the next one from Paul Cathcart.
Yes, so on that note, Paul Cathcart is asking, is there a plan to identify the best surgeons of each technique and then try and distill how they get the best outcomes technique-wise to allow the development of an advanced training module to improve outcomes across the board? Do you have any such plans, Anders?
Well, I think John explained that in a very nice way. I mean, what is the best surgeon? I mean, you need to look at functional outcomes, you need to look at oncological outcomes, and so I think the definition of the best surgeon is quite difficult. But experience is, as we've shown, experience is important and annual volume is important. So, I mean, you can report your experience, you can report your annual volume, your functional and oncological outcome. But then, of course, it's influenced if you are the only surgeon at your center performing all the difficult cases, then the results will be different from maybe another surgeon.
Yeah, I think training is the essence, particularly at the start of your career. I obviously feel the fellowship training is the appropriate way to go. And then it's all about the technique. And the value now is with webinars and with the internet, you can review other people's work. We have 2 robot theatres side by side, and I'm quite often going into the theatre next door and having a chat to the surgeon. And there's peer review going on there. They watch you operate, you watch them operate. And so I think for our trainees, it's going to be better than the old days of open surgery where you're fighting with clashing of heads to actually see into the pelvis. So hopefully that will make a difference.
So I think we're going to have to draw stumps there, I'm afraid. We promised we'd stick to half an hour or just over. A huge thank you to our guests and panelists, Anders Bjartell and John Yaxley. Thank you to my co-host, Sigrid Carlsson. Thank you to all 57 of you or so who've joined us live just now. We're going to make the recording of this webinar almost immediately available on YouTube with extracts circulated on Twitter. Please do share and comment using the hashtag #LAPPROSurgeon and tag @BJUI Journal. Ask any of the questions that weren't answered, and apologies to those who asked questions that we didn't answer. The authors and the editorial team will keep a close eye on these to offer thoughts, answers, and opinions. Until the next time, that's it from BJUI Webcasts. Thank you very much for joining us.